As we all know, non-muscle invasive bladder cancer has a high rate of recurrence. Some of our patients also progress, so we need to do surveillance and follow-up to these patients, and they have to be compliant with the schedule of the follow-up, because we need to identify their recurrences as soon as possible. In some of the tumors, it's every 3 months at the first years, so it's important for them to be compliant with the follow-up schedule and to come to all the tests we order, because we need to we don't want the recurrences to have a negative impact in their prognosis, and that's why they have to be compliant and come to the follow-up. Well, usually, especially for intermediate and high-risk patients, the follow-up is indicated every 3 months during the first years with cytology and cystoscopy, but we try to reduce the burden of this, the intensity of these cystoscopies, because it is an invasive procedure. Patients are not really happy with this, so we usually try to alternate, or even in some of them, if they have 4 follow-ups every year, we try to do 3 follow-ups with a biomarker and then 1 follow-up with cystoscopy plus cytology. Well, the use of biomarkers has several advantages. Among them, we can find that it's easier and faster for the patient. They just bring their urine sample, they take it to the laboratory, and they also avoid coming to the coming to the hospital for an outpatient procedure as a cystoscopy, where they have to wait before they have to do the cystoscopy, and they can also avoiding the cystoscopy, they will avoid eventual complications, like if you are doing repeated cystoscopies, urethral strictures, UTIs, sometimes hematuria, or some days with lower symptoms like dysuria or whatever. So we believe we can use biomarkers for these patients to reduce the intensity of cystoscopies and to make our patients more comfortable with the follow-up of this highly recurrent disease. Well, personally, I believe that every patient would have a benefit of using a biomarker. Also, although in the EAU guidelines it's only recommended for low or intermediate risk patients, I also believe that the high risk patients, where they have the most intense follow-up, will benefit from that. In fact, biomarkers have a really high, over 99% negative predictive value for the to detect a high-grade recurrence. So in our center, we use biomarkers for all groups of patients, both low, intermediate, and high risk, because in the event in a low or intermediate risk patient you have a high-grade recurrence, you are very confident with the test that you will detect it. The only thing is we have a very wide experience with biomarkers in our center, and I just wanted to highlight the preference of the patients when they come for the biomarker over cystoscopy, and usually patients, some of them even do not want to undergo any cystoscopy anymore, but we try to convince them that we may do, as I said, for high risk, 3 biomarkers and 1 cystoscopy per year, so we reduce the intensity of cystoscopies in a 75%, and patients are quite confident with the biomarker. If you tell the patients, because you have to explain what the biomarker is and the performance and everything and the relevance of this, and they usually prefer it over a cystoscopy.